Okay. So thank you very much, everybody. We will have a Q&A on the bottom. So after each presenter, if you have some questions, please feel free to ask questions. You will be muted, so I will be reading your questions. So don't make them technically too hard because I probably can't pronounce them. It's a joke there. People who know me know I'll mess up a lot of words. So thank you very much for joining us. 1 second. Okay, we have everybody here. So I will start the opening because I know a lot of you, we've got nearly 200 students on, or 200 individuals on board. So thank you very much for joining us on this rainy afternoon on St. Patrick's Day, as it turns out. So I am Mary Rojas. I'm the director of the Medical Student Research Office. I'd like to welcome you to the afternoon portion of our research day. For those of you who maybe were not able to come to the poster sessions, I encourage you to click on the QR code you see here on the side. That will take you directly to our abstract book so you can see the wonderful abstracts for the various presentations today. I'm going to minimize some of these. So we have had several hundred poster presentations not too long ago, starting from 12:15 right up to this point. So I hope that many of you have had a chance to view these. I facilitated 2 sessions myself and they were pretty amazing. So I'm always very impressed to sort of see the work that's been done, and particularly when you get to the point that you're drawing conclusions. Most of you have worked towards today. Since you started medical school here about 14 months ago, you started off by looking for mentors, projects, doing your studies, synthesizing results, putting your poster together, talking about what you found, talking about the challenges that you've encountered. That's all part of the process. Research doesn't always work the way we think it's going to work. So part of it is adapting to that. And particularly for your classes, you have been faced with a lot of constant uncertainty, including today. Changes you've had to adapt to, things you've had to overcome, obstacles along the way. And I thank you all for doing that and being very adaptable. We've had to make a lot of adjustments along the way, but it is really impressive to see how far, in spite of all of that, you're working to be able to accomplish what you've accomplished. Embedded in your DNA is perseverance, drive, inquisitiveness, and quest for knowledge. All are essential qualities for a scientist and physician. May I ask that you hold on your questions till we move a little further so I can, they just keep popping up. So what you see here is one of the pages of our abstract book. And so this is the topic areas. It's towards the end. You could see that our students have done research in areas, in over 30 different areas, from adolescent health to well-being and resilience. They have used a range of different methodologies, from basic science methodology, clinical research, medical education, medical humanities, quantitative, qualitative methods, micro-simulations, machine learning, applying anti-racism framework, just to name a few. Your success today and always is our success. It's definitely impressive to see all that. But I do want to point out, when I say our, who do I mean? Like, who are these people behind the scenes? And so I'm just going to run a few slides with individuals' names, because there's no way that we could have gotten to today without thanking and recognizing a lot of people. And my apologies if I've missed anyone on this list. First are the track advisors who have worked with you since pretty much your first few months here, helping you to refine your questions, giving you feedback on your abstracts. The event committee, MSRO, Medical Student Research Office team, has been working since day one. It takes a while to produce this type of an event, which is why we ask students, submit abstracts by this date, submit your posters by this date. But I'm hoping that you saw the fruits of this. Our hearts are always in the right places, want to really showcase the wonderful work you've done. The folks that have processed your summer funding to make sure you got your summer stipends. The folks that have designed the abstract books, looks pretty snazzy, please take a look at it. The volunteers today that have helped keep us running and flowing despite some of the challenges that we faced. The poster facilitators, thank you very much, who facilitated various sessions earlier. The mentors, and I know it's hard, there's a lot of names and it's really teeny tiny, but that basically the effect is a lot of mentors have worked with a lot of you. And so here is the poster presenters. We've had over 130 poster presenters, and we've got 4 platform presenters you're going to hear in the next few minutes. This is the rest of the program for today's afternoon. Dr. Chakrani will be next, Dr. Muller, and then we have 4 students I'll be introducing, and then we'll be closing the event. So as I said, if you have questions, please add them towards the end of the student presentation, and I will read the questions out for the students. So with that said, I'm going to turn it over to Dr. Chakrani, who is the Anne and Joel Ehrenkrantz Dean for the Icahn School of Medicine at Mount Sinai, President of Academic Affairs at the Health System. Dr. Chakrani.
Yeah, thank you, Mary. And first, I want to congratulate you, for leading this effort. Fantastic job. I also want to thank the mentors from so many different departments and institutes at Mount Sinai for providing guidance to our students. And to the students, I have one word: awesome. I've read all the abstracts. They come from so many different areas, so many different techniques. Many of the findings are very important in understanding human disease, stress, developing new treatments. It's just amazing what you have accomplished, even during the challenges of the pandemic. So it's fantastic. I've read all the abstracts. They're just terrific. All of us are very proud of your accomplishments. And I look forward to, hearing the presentations to come. Dr. Muller?
Thank you. And just really adding my words of welcome to everyone, and my deepest gratitude to Mary Rojas, Grace, Yakir, the whole MSRO team. You guys are really awesome and have done incredible work under sometimes dire circumstances these last 2 years. Of course, congratulations to Liza, Zach, Lauren, and Amara, and wishing you the best of luck. And to me, this is always an exciting day to see the culmination of work of people who are expressing their interest and passion through research, through kind of challenging conventional wisdom and coming up with questions that are not yet answered and figuring out how to answer them. It's just really, it's what makes medicine great. So we really appreciate all of your contributions, and I look forward to hearing the presentations.
Thank you. Thank you, everyone. So let's move to our star part of this event. First will be Lauren Alpert, second-year medical student.
Can you see my screen?
Yes.
Okay. Well, thank you so much. Today, I will be discussing the research project that I began working on last summer, entitled Associations Between Prenatal Exposure to Fine Particulate Matter and Age for Impulse Oscillometry, Effect Modification by Maternal Atopy. So to give some background on this topic, previous research has demonstrated that children with impaired lung function by school age are at increased risk for developing chronic respiratory disease later in life. Our group has previously found that higher in utero exposure to fine particulate matter, which is also called PM 2.5, is linked with worse childhood lung function. And additionally, we know that maternal atopic disease, including asthma, is independently linked with worse childhood lung function. So given all this background, we hypothesized that children born to mothers with higher air pollution exposure during sensitive windows in pregnancy would have worse lung function in early childhood, especially if there was maternal history of atopic disease. And so we analyzed data from the Programming of Intergenerational Stress Mechanisms, or Prism study. Prism is a very robust prospective pregnancy cohort with racially and ethnically diverse mother-child dyads recruited here at Sinai. And the Prism study investigates the effects of environmental exposures on child development and respiratory health outcomes through different means, including maternal questionnaires and also lung function assessments in children. So in terms of measuring prenatal air pollution exposure, the Prism study was able to estimate PM 2.5 levels at the site of maternal residence over the course of gestation for the mothers in the study by taking into account a lot of different factors. Some of these included elevation, distance to major roads, temperature, wind speed, time of year, et cetera, at the geocoded residential address for each mom. And then gestational PM 2.5 exposure estimates were calculated by averaging daily predictions over each week of pregnancy for every mother. And so in order to measure lung function in the children in the study, we use something called impulse oscillometry, or IOS. And each child performed multiple reproducible trials of tidal breathing into a mouthpiece for 30 seconds at a time. iOS was a reliable way to assess lung function in this pediatric population because it's effort independent. And so that makes it different than traditional spirometry. And another advantage of using iOS over spirometry was that it allowed us to distinguish between resistance in the large airways versus the small airways, whereas traditional spirometry is not as effective at evaluating the small airways. In our statistical analysis, we used multivariable Bayesian distributed lag interaction models, or BDLIMs, in order to identify sensitive windows during pregnancy for the effects of prenatal PM 2.5 exposure on impulse oscillometry outcomes in children, as well as to evaluate effect modification by maternal atopy. So I worked with my research mentor to develop a directed acyclic graph, or DAG, and identify the variables that we wanted to include in our statistical models. So we ended up adjusting our models for maternal education, marital status, and secondhand smoke exposure during pregnancy, as well as child sex, race, gestational age, height, and weight. And initially, we conducted our BDLIM analyses in the overall sample, and then we repeated analyses examining effect modification by maternal atopy. And so here are the demographics of our study population. We ended up analyzing data for a total of 228 children who were a median age of 4 years old at the time of their impulse oscillometry assessment. 61% of these children identified as non-Hispanic Black, and 32% of children identified as Hispanic. And then 56% of mothers reported a prior atopy diagnosis. And for our purposes, that could include asthma, allergic rhinitis, or eczema. And so here is a visual representation of a BDLIM identifying associations between PM 2.5 exposure and resistance at 5 Hertz at age 4 years. So we see that increased prenatal PM 2.5 exposure between 4 and 14 weeks gestation was associated with increased resistance rather at 5 hertz, and that is a representation of total airway resistance. And here the BDLIM also identified a statistically significant cumulative effect where higher PM 2.5 exposure over the course of the entire pregnancy was associated with higher total airway resistance. In this case, our models did not suggest effect modification, meaning that children born to mothers, both with and without atopy, were similarly affected. And we saw comparable results when we ran this model for small airway resistance instead of total airway resistance. And so in contrast, here is a BDLIM that did show effect modification by maternal atopy. So we can see that among children born to mothers with a history of atopy, higher PM 2.5 exposure between 1 and 8 weeks gestation was associated with a more negative reactance at 5 hertz. And that's a representation of more negative elastic recoil in the small airways. But this sensitive window was not seen in children whose mothers did not have a history of atopy. And when we looked at the cumulative effect here, you can see that the elastic recoil trends more negative in children whose mothers had a history of atopy, but it trends more positive in children whose mothers did not. And we saw a similar effect for area under the reactance curve, and that variable represents respiratory compliance. And so in summary, we found that in all children, higher PM 2.5 exposure was associated with higher total airway resistance and higher small airway resistance. But then just among children whose mothers reported a history of atopy, higher PM 2.5 exposure was associated with more negative small airway elastic recoil and higher respiratory compliance. And these findings are consistent with something called airway dysynapsis, which is a mismatch between the size of the airway tree and the size of the lungs associated with higher prenatal PM 2.5 exposure. And this is of particular importance because the airway branching pattern that's associated with dysynapsis is determined early in life and is related to risk of respiratory morbidity and decreased lung function later in life. So these findings suggest that air pollution, especially in the presence of maternal atopy, has implications for lung health over the life course. And so in terms of future directions, it will be critical to continue elucidating the modifiable environmental influences on lung growth and development, and identify those patients at greatest risk early in life to optimize lifetime respiratory health. And this draws attention to the importance of reducing air pollution exposure during pregnancy and promoting maternal health in order to improve intergenerational effects on lung health over the life course. So I'd like to thank the MSRO team, all my colleagues in the Prism Study, Dr. Rosalind Wright, and my mentor, Dr. Allison Lee, for all of their help and support in making this presentation possible. And thank you all so much for listening. I'm happy to take any questions that you may have.
Thank you so much. Just to remind folks, you can put questions in the Q&A box. I'll give it just a moment. Lauren, maybe can you pull up your last slide with your recommendations or your moving forward? 1 second, we've got a question. Amazing job. one of the comments for you. Moving forward, elucidate modifiable environmental influences on lung growth. Do you have like any sort of suspicions of what might those environmental factors that could be modifiable by, by healthcare?
Yeah, I mean, I think my one thought was, increasing affordable housing in locations that are not so close to air pollution exposure, like close to major roads or highways. I guess that's more of a systemic or a public health type explanation, but I think, that could potentially be beneficial in a way to modify those types of exposures during pregnancy.
Thank you. Yeah, it seems like there's so many environmental factors. We're all breathing the same air. We're all exposed to a lot of things, but certain areas are more of the epicenter of it. So I guess trying to limit some of those characteristics within their environments. Thank you so much. I'm going to, let me see. Yeah, you got another wonderful. Let me read to you, Lauren. I guess, sorry, we just got a comment for you. Lauren, this research is stellar. I'd be curious to know more about the implications regarding intergenerational/life course effects, and also how you think the recruitment from Sinai influences these results.
So let me see. I mean, yeah, I think a takeaway from this research was that we can see that environmental exposures, happening during pregnancy, even before the child is born, at very early weeks in gestation, can have impacts on lung health at 4 years old. But we know from other research that it can cause things like asthma down the line or COPD down the line. So yeah, I think there are these long-term effects. And then in terms of the patients we recruited from Sinai, I think a lot of these patients, as I mentioned, because they're sort of local to our hospital, are close to these types of environmental exposure. So it is really pertinent to their health and well-being, even before a child is born. So yeah, I do think it's quite relevant to our patient population here.
Exactly. And your patient population were specifically in the, I believe the Mount Sinai, right? Mount Sinai as opposed to sort of a national sample.
Yeah, right. They were recruited from the OBGYN clinic here at Mount Sinai Hospital, and then also at the OBGYN clinic at Mount Sinai West. So 2 Sinai sites.
Thank you very much. I think we'd all agree this is all very interesting and very impactful research. Next presenter I have the pleasure of introducing is Zakaria Chakrani, who also second-year medical student. Zach?
Great, thank you. All right, let me share my screen.
Yep, we see it.
Great, thank you. All right, so today I'll be talking about prolonged opioid use after open reduction internal fixation of tibial shaft fractures. So just to go over what tibial shaft injuries are, they're pretty common, happening at around 500,000 times per year in the US, and they can be due to low energy forces like sporting injuries and falls, as well as high energy forces like motor vehicle collisions. One of the ways that we treat it is with an open reduction internal fixation. And so what this is basically we want to realign the bone fracture first and then use a metal implant to hold the bones together. And so on the right here, we'll see there's an intramedullary nail that's holding the bone together so that we're allowing it proper time and the ability to heal. And so as we know, in America, there's currently an opioid crisis. And unfortunately, orthopedics does play a role in this. And so we see the highest rate of post-operative opioid usage being in orthopedics. And we also see orthopedic patients representing the highest prevalence of chronic opioid usage. And so you would think with opioids being such a big part of treatment, there'd be some sort of guidelines for it. And although there are guidelines for prescribing opioids for chronic pain, there aren't any guidelines for acute pain in the post-op orthopedic setting. And so this tends to be something that physicians deal with the patients depending on their specific pain tolerance as well as the fracture type. So the objectives of this study in particular is that we wanted to determine the rate of prolonged opioid use and the associated risk factors following opioid exposure after this surgery. So for the methods, what we did was we did a retrospective study. We used the IBM Market Scan private commercial national claims database, and we got data from 2014 to 2017. We identified 1,951 adult patients who specifically filled an opioid prescription after ORIF of the tibial shaft fracture. Within that group, we have a subgroup of 1,508 opioid naive patients, and these are patients that didn't use opioids 1 year prior to surgery. Our primary outcome is prolonged opioid use, and the way that we define this is filling an opioid prescription between 91 and 180 days post-op. So the reason why we picked this time frame is because once you're out of surgery, you're going to feel the pain, and so you're going to want to take those opioids to feel better. And in previous literature, it's been shown that it takes around 90 days for patients to start feeling better and start coming off of the opioids. And so for this paper, we've decided that anything past that 90-day mark would be considered prolonged opioid use. And for the analysis, we did a multivariable logistic regression and calculated odds ratios with the 95% confidence intervals. So looking at this first table, these are the demographics. The first thing I want to point to is the rate of prolonged opioid use. We do see a rate of 15.7% in this group. We also did this table so that we can compare both the prolonged opioid use and the no prolonged opioid use groups and see which risk factors have differences. And so we see here there's sex, there's age. I'll explain the Charleston-Dale Comorbidity Index. This index is looking at comorbidities like cardiac disease, pulmonary disease, AIDS and cancers, as well as diabetes. And so there's a scoring here, and we use this to simplify our analysis. We also wanted to look at comorbidities that aren't included in this. And so we also added obesity, smoking, back pain, as well as other pain, mental health disorders like anxiety and mood disorder, as well as drug and substance use disorder. Additionally, we wanted to look at the specific medications looked at in the perioperative setting. And so this time period is 14 days prior to surgery up to 7 days post-surgery. And we looked at NSAIDs as well as some opioids like fentanyl, morphine, and tramadol, which are different here. And another thing we wanted to do is we wanted to standardize how we look at it. And so we used OMEs, and these are oral morphine equivalents. So we calculated this so that we can be able to look at all the opioids in the same way. And so we see here, for example, in the prolonged opioid use group, there's a median of 700 milligrams. We also definitely wanted to look at the pre-op opioid use. This has been shown to be a really large risk factor, and so we definitely want to include this in our analysis as well. So we calculate odds ratios, like I said, and the way that we're showing it here is in a forest plot. And so I'll take you through this. We see the risk factors here on the left, right? We see the odds ratio of 1, which shows no association. There's a vertical line, and anything to the right of this line is showing a positive association, and anything to the left is showing a negative association with prolonged opioid use. And so we see age at the top. There's a slight association. There's a larger association with perioperative OMEs in the 4th quartile. So this comes out to around 1,200 to 2,700 milligrams, and there's a 2.48 times more likelihood to have that prolonged opioid use in this group. We also see a DAO, which is the comorbidities, a DAO index score of 2, being significant here and having a large association. Although there is a large confidence interval here, it is something that we can look at for sure. And we also see that the DAO 3+ is protective, which is a little odd here, but I think it'd be fair to interpret this as being a score of 2 and more. In addition to those, we see slight associations with smoking, as well as mood disorders, perioperative morphine, and tramadol. And like we predicted, we see that pre-op opioid use has the largest predictive value for looking at prolonged opioid use, coming at 3.91 times more likely. So that was the full cohort. We also wanted to look at the opioid naive cohort that I mentioned. And so we see a lot of the similar risk factors, right? And so we wanted to make sure that patients who aren't using opioids prior are also considered for these risk factors. And so we see, once again, age, as well as perioperative OMEs in the 4th quartile, smoking once again. And what's new here, we see other pain conditions, drug and substance use disorders, as well as perioperative tramadol. We do see a large association here in acetaminophen, but the confidence interval again was really large, and it also was insignificant. So just to wrap this up a little bit and talk about some discussion points, this is the only study so far looking at tibial shaft fractures and prolonged opioid use. And so that's another reason why we picked specifically tibial shaft injuries. And we see here that prolonged opioid use is not uncommon in this population. So coming at, again, 15.7%. Aside from the pre-op opioid use, we do see common risk factors between the full cohort and the opioid naive cohort. And these include non-modifiable risk factors like age, as well as modifiable risk factors like perioperative opioid dose, perioperative tramadol, and smoking. We do also want to acknowledge some limitations. So we see that there's this is a retrospective review of specifically privately insured adults between 18 and 64 years old. So definitely not indicative of the entire population, and may actually be underestimating prolonged opioid use. Additionally, due to the nature of the database, we could only see prescriptions filled, which I emphasized earlier, and not exactly how much was actually taken by the patients. And so this is something that should be taken into account. We also know that patients might be taking opioids due to another injury, right? So it doesn't have to be that exact fracture. And so we tried to go around this by excluding patients who underwent any additional procedures requiring anesthesia in the 6 months post-surgery. Putting this into context and looking at other literature, other studies have shown that the rate of prolonged opioid use is similar to ours, which is at 15.7%. And we see here 35% in traumatic musculoskeletal injury, as well as 24% and 7 to 10% in ankle fractures, and 6 to 7% in a surgical correction of hallux valgus paper. The risk factors are also quite similar, seeing tobacco, substance use disorders, mental health disorders, and comorbidities as risk factors for prolonged opioid use. And like I said, these are quite similar to our study as well. And so the big question is, all right, all this information is given to you, how can we apply this? We know that prescribing opioids is a very complex issue. Like I mentioned, physicians are with the patient. They have to make sure that that patient is discharged and feeling okay and feeling good. So we don't want to underprescribe, but we also don't want to overprescribe. And given that there are no true guidelines, this is really changing from patient to patient. So it has been shown, unfortunately, that physicians do overprescribe opioids, and patients end up not really using all of them. And so given that one of the risk factors that we saw is perioperative OMEs in the 4th quartile, that specific dosing, that large dosing, we do want to make sure that physicians are finding the fine line between making sure that the patients feel good, but not putting them at risk for prolonged opioid use. So that's something that should be considered. In addition to that, physicians should be identifying these risk factors in the office and making sure that we're counseling at-risk patients before they leave so that they know what the risk is and how to combat that. As we saw, there are similar risk factors for both opioid naive patients and patients who have used opioids before. So it's really not enough to just be saying, have you used opioids before? Okay, then we can talk about the risk, right? So our results actually also have implications for future research. And so it'd be very interesting to see how the inclusion of pain scores affect our outcomes. And it'd also be very interesting to see if there's a specific threshold of perioperative opioid use. And so we saw in our paper, we looked at interquartiles, right? So it'd be interesting to make it a continuous variable and see if there's a specific point that we shouldn't be passing. And I'd like to thank Dr. Forsch and Dr. Porin, as well as Nicole and Broca and the MSRO staff for helping with this presentation. And I'll be taking some questions.
Thank you so much. So please put your questions in the Q&A. So I do have a question. I'm wondering, when you did your analysis, it didn't seem like there were main effects or minor main effects for age and so forth. Have you done statistical interactions to see if there's, maybe there aren't main effects that are that strong, but there could be conditional effects by age or by some of these other categories?
Right. Yeah, that's definitely an interesting point. We haven't looked at the interactions yet. We did try to identify the risk factors through that first analysis, and then looked at it through this, but it'd be interesting to see if, like you said, if the risk factors are interacting with each other.
And I'm also curious about the data that you have. You probably haven't done this, but sometimes when people are still in pain, right? Some people might continue to have pain. In this data set, is there any possibility of looking at individuals that were on opiates and then maybe are changed over to an NSAID? Right.
So yeah. So the NSAID issue is very important because that's another route to take instead of going through the opioids. We didn't look at prolonged. I mean, after the 90 to 180 days, if they switched over. But that is definitely something to see if they still feel that pain. And if we
Yeah.
have pain scores and we can track it post-operatively and see if they're taking the medications, it'd be very interesting to see what the outcomes are.
Yeah, it will be interesting to see, because I think this concept of, once you're in a lot of pain and those pictures look pretty devastating, right? And you sort of have this fear of, I don't want to be in pain anymore. And so you might continue it. But, who knows, it might be relieving, and individuals might be, if you could look at that and see this group is doing better, or some of the quality might be kind of interesting.
Yep.
Thank you very much. You're definitely getting a lot of amazing work, Zach. Congrats, Zach. There is a question here.
Sure.
Let me ask it. As an alternative, can they use long-acting local/regional anesthetics, peripheral nerve blocks for the brief post-op period?
Yeah, so that's a great question. I don't actually know the specific answer for that. That would be a clinical question, but it'd be something to look into for sure. Yeah.
And I guess you can also explore in the data if they have other alternatives when people are being converted over. What are they being converted over to?
Right.
Which would be kind of interesting. And another amazing presentation, Zach. Congrats. Thank you so much, Zach. And so now we will turn it over to another, I just lost my presentation. Another very interesting presentation in a different direction. We have Liza Mcgill, also an M2 student. Liza, you got it.
Everyone. Hi, my page is loading.
Yeah, we got it. Go to the beginning. There you go.
Great. So I'm grateful to know so many of you. If I haven't met you, my name is Liza Magill. I'm a second-year MD/MPH student at Sinai, and my project is characterizing non-responders to an HIV disclosure intervention and local average treatment effects of disclosure on outcomes for children living with HIV. And that's a mouthful. And my goal is by the end of the presentation, you understand what this title means. So hopefully when we go through, you'll learn with me. So I'd like to start by centering this presentation in Kenya, which is where this work was done. And AMPATH Kenya is a collaboration between Moi University, which you can see in the bottom left, with Moi Teaching and Referral Hospital, as well as a consortium of United States universities led by Indiana University, including Mount Sinai. You may have seen Brown as a collaborator on my project, as well as various universities all around health in Eldoret, Kenya, which is a rural area of Kenya. And our project on the top left is focused in HIV/AIDS, but you can see that AMPATH has cross-collaborative work across the United States and Kenya for care, training, and research across all of these different areas. And I want to center this here because this is the most important, and their work is really what built into my analysis today. And so, like I said, our research is based in HIV care, and my analysis is specifically in pediatric HIV care, looking at the concept of disclosure. So children who are perinatally acquired HIV can be disclosed their HIV status at many different points throughout their childhood. And as clinicians and in the medical field, we understand that autonomy and knowledge of HIV status can be important, especially as kids move into adolescence, for autonomy of care, knowledge of what's happening, and treatment adherence. And the World Health Organization recommends that the HIV disclosure process happens from the ages of 6 to 12, which means that starting at age 6, some information is given, and through age 12, this disclosure process happens, so that by the time a child is 12 years old, they understand their HIV status fully, and that what the disease they have is called HIV. But across the lifespan, that's different, and across different areas, that's different. And Sub-Saharan Africa has the highest prevalence of children with HIV in the world. And studies across the region have found that the HIV disclosure rate for adolescents, which they define as age 13, is between 15% and 64%. So in some contexts, that's only 15% of children age 13 actually know about their HIV status. And at AMPATH in Kenya, a qualitative study found that 42% of 11-year-olds and 62% of 14-year-olds knew their status. So in their community at AMPATH, disclosure was not prevalent. And non-disclosure was related to HIV-related stigma. So they asked parents, why aren't you disclosing HIV status to your children? And they described stereotypes associating HIV with immorality and death, and specifically a fear of negative psychosocial reaction by the child and fear of mental health. And as someone interested in psychiatry and mental health, this is really interesting. And this is what led to a project. clicking, yep, that was called Hadithi, which was a cluster randomized control trial run by my mentor, Dr. Vreeman, the director of the Arnold Institute of Global Health, that was conducted in 8 facilities across Western Kenya from 2013 to 2015 to try to figure out, can we develop a psychosocial supportive intervention for parents and children to alleviate the fears and to increase disclosure in this population. And so Hadithi is called Helping Empath Disclose Information and Talk About HIV Infection, and it included group counseling sessions, individual counseling sessions, and culturally tailored resources to encourage disclosure. And the hope was by increasing disclosure, it would also increase CD4 adherence, CD4 percentage, increased CD4 percentage, improved HIV adherence to medication, as well as improved mental health and psychosocial outcomes. And so they tracked children living with HIV for 2 years post-study to figure out what those assessments were. And so at the end of the study, they did find statistically significant increase in incidence and prevalence of HIV disclosure among children, which was their overall goal, which was great. But they found that after 6 months, similar to what parents had feared, there was actually a statistically significant decrease in mental health outcomes among children who participated in the intervention, which means that yes, post-intervention, there was a negative mental health implication that did stabilize over time. And so by the end of the 2-year period, there was no statistically significant difference. But after figuring out these results and not really knowing what happened, there were big questions, because as I put in the top here, 20%, so 1 out of every 5 caregivers who completed the intervention still didn't disclose to their child. So if their child was 12 or 13, 2 years later, by 14 or 15, their child still hadn't had their HIV disclosed to them. And mental and behavioral outcomes were based on intervention participation, not specifically on disclosure. And I'll get into that in a second. And so my analysis this summer looked at, 1, can we figure out who are these caregivers who will or will not disclose HIV status? So we know who they are, and we can better target programming to help improve disclosure. And 2, what are, go back to my title, the local average treatment effect of disclosure? Does disclosure itself, separate but intertwined with the intervention, lead to different mental, behavioral, and CD4 outcomes than just looking at intervention status? So I'll explain this more here. So what I did was a instrumental variable analysis. And at the top, you can see what the first study looked at. So they looked at the treatment, which was the counseling intervention. And they looked first at the bottom, did the intervention increase disclosure? And then separately, they looked at, did the intervention improve mental health outcomes, HIV outcomes? That was the study that I spoke about that Dr. Vreeman ran. And we looked at instead, really what the intervention was looking at was, will the intervention improve disclosure? And with this disclosure due to the intervention, will that improve mental health outcomes or HIV outcomes? Can we look specifically at disclosure in this equation? And the short answer is you can, using some pretty complex statistical methods. So bear with me as I drag along, but I hope when we get to the results and the discussion, you'll be able to follow. So first, we predicted who was going to disclose. So for that, we did a least absolute shrinkage and selection operator, or LASSO regularization, which is a specific logistic regression model, specifically for models when you have many covariates that might be similar. So we had lots of mental health, behavioral health, HIV outcomes that could be correlated with each other. So we chose this regression model, and we looked at 80 different clinical and demographic covariates to see, did this statistically increase or decrease the likelihood that a parent would disclose after completing the intervention. And we did bootstrapping at the bottom, which is basically repeating it a bunch of times to make sure you don't have random mistakes. So here's what we found for part 1. The table on the left gives you the demographic characteristics of the participants. So participants who completed the intervention versus those who didn't. And I didn't put p-values on this table because none of them were significant. So you can see that there's no real differences in the intervention versus the control cohort here. But we did find, after doing this LASSO regression, that there were only two covariates that predicted responsiveness. The first was the time that a child had been on antiretroviral therapy. And 2, whether the caregiver identified as isolated, and I'll talk a little bit more about what that means, during the intervention, before the intervention started. And so you can see at the bottom, the regression statistics showing that significance with the p-value less than 0.05. So if we look a little bit more into each of these 2 covariates, we can see that the first is caregiver isolation. Now, what does that mean? How did we define that in the study? So caregiver isolation was defined as responding ever happened to the prompt because the child or someone else in my family has HIV, or because I have HIV, I am isolated or avoided by others. And we thought that it was really significant that this was one of the two that came out because it really speaks to HIV stigma, isolation, avoidance. And it said that even after an intervention trying to create community and individual resilience and ideas to move this forward, stigma still stood in the way as a barrier that stopped parents from disclosing to their kids. And two, the duration of time on antiretroviral therapy is really important. And interestingly, we found that increased time on ART actually decreased the likelihood that a parent would disclose to their child, which on first glance seems to not make sense because a child on ARVs longer may have a more serious course of HIV, maybe not, but at least would be exposed to a healthcare center for a longer period of time. But we actually found that when doing some qualitative talking to parents afterwards, it may have actually been helpful for while children were entering ARVs or starting a new treatment, for that to be a time that it would actually make sense for parents to talk about. You're starting a new medication, things are changing, here's why. Let's start this disclosure process with you. So that was a really interesting finding that we hope can inform how this intervention can piggyback on existing clinical outcomes and clinical processes for children with HIV. So we said, okay, great. Here's who's disclosing and who isn't, but does that matter? Does disclosure itself impact kids and their outcomes with HIV? And so for that, we did this more specific IV analysis, which I talked about at the beginning. And there's a two-stage least squares regression approach where there's two stages to the analysis, and we compared it with kids who just were in the intervention group. So we looked at children who were in the intervention group, what were their outcomes, similar to the previous study, versus kids who were in the intervention group and were disclosed to. And by adding in the IV analysis, we can look at both intervention and disclosure to really look at disclosure as a piece itself after participating in the intervention. So what we found was this big bump of tables, and I'll spoil it, which is that none of the confidence intervals were significant here. And the bolded ones that I put in the middle were the only ones that might be clinically significant, which interestingly were 1 year and 18 months CD4 percentage. There was increased percentage CD4 for children who were disclosed to who received the intervention versus those who weren't. But everything else, and even these, the 95% confidence interval, were not significant. And so this tells us some interesting things. One is that was our study powered, right? Which is we had 130 patient caregiver dyads. And so that is one thing that we're thinking about, which is why we're looking at, is there possible clinical significance, which it really doesn't seem like, other than this CD4 percentage change. And two, what this really tells us is that parents fear that their kids' mental health, behavioral health, quality of life is going to decrease after receiving their HIV and after receiving disclosure didn't actually happen. So a lot of these fears around disclosure itself, they would get their kid in the intervention, but they didn't want to disclose it to them. That piece that caregivers were so afraid of didn't actually impact their mental health or their quality of life. But at the same time, it also didn't improve it. So there are places that we can grow around how to create the intervention so that it not only focuses on disclosure, but also can improve and enhance life for kids living with HIV, not just keep them stable. So overall, I'll just repeat a little bit of what I said coherently. So if you missed all the stats, come back now. HIV-related stigma may isolate caregivers and impact their willingness to disclose HIV status, even if they complete a counseling intervention. Disclosure counseling interventions may be more effective if conducted soon after a child begins antiretroviral therapy, depending on whether that happens within the recommended ages for disclosure. We're not trying to say at age 4, this should be what we should be doing. And finally, disclosure when completed post-intervention did not worsen children's mental health scores as feared by parents. It also didn't improve mental health quality of life or CD4 pending clinical significance. So finally, there are some limitations. The first, as I mentioned before, is the sample size. We can't control how many pediatric children with HIV live in our cohort, but we had 60 samples for the predictive analysis and 130 for the instrumental variable analysis. And the other piece that I want to bring up is interesting and I think applies to other studies, which is how you define disclosure limited our sample size, because there were some situations in which parents thought their child was disclosed. They thought they told them about their HIV status, but the kid didn't know when asked directly alone, or vice versa. A child knows why they're coming to the clinic every week. They've figured it out, but their parent still thinks that they're not disclosed. And so those discordant groups were not included in this analysis, and there have been sub-analysis done on this group. And then finally, I talked about the power and whether we're looking at clinically significant or non-significant results, although both were not very promising in this case. So way forward is looking at how we can pilot adaptations of the program to integrate additional mental health and treatment adherence counseling to improve, not just stabilize, mental health and HIV outcomes, to educate family members that mental health did not worsen post-disclosure of HIV, and that's going to take a lot of qualitative and community-led work. And finally, tailoring educational components to the people that did not and did disclose. So focusing on HIV-related stigma, focusing particularly maybe on new ART patients and caregivers and children that need additional support. So with that, I'd like to thank Dr. Freeman and Dr. Erin Baum, my mentors for the summer, the MSRO team, the global health team. And I would not want to end this without thanking the patients living with HIV, their families and care teams in Eldoret, Kenya, who participated in this research. And just thank everyone for giving the stage, not only for hard science, but global health, public health, and equities research in this forum. So I'll take any questions. Thanks.
Thank you, Liza. There is a question here, and we'll probably have a few more. I have some questions roaming in my head. This was such a thoughtfully done project and presentation. I'm wondering how this could be applied to HIV disclosure interventions in other locations. And you're getting a few congrats also.
Thank you, everyone. Thanks. Yeah, I think first of all, I want to say one of the big things when we think about this type of research is that it can't directly be applied to a new setting. So I can't say because this worked in rural Kenya, this will work in rural Uganda or rural Rwanda. But what we talked about as a team and what I think is really interesting is looking at how we integrate clinical processes like starting antiretroviral therapy or working with parents who may be receiving HIV treatment themselves and coming into the clinic. How can we better integrate the process of disclosure counseling and mental health and psychosocial support into those programs? And that's something that I feel grateful there's a huge literature on, at least in sub-Saharan Africa, around pediatric HIV, but specifically finding that this is a good time to start the disclosure process, I think is something that could be applied across contexts.
Thank you. I'm wondering if along the data that you've collected or other data you've seen, have there been maybe more qualitative studies where the adolescents themselves were asked about, would you have liked to have known earlier? How did you feel when you found out? Just to get a sense directly from them, what impact it had on them.
Definitely. Thank you for that. Yeah, obviously the voices of adolescents are some of the most important here. It's tricky to ask, do you wish you knew when you don't know you have HIV? Right.
Exactly.
So
the groups that, right, we're disclosed.
But we were lucky that half of the cohort actually was disclosed to, which was not expected when the HEUTH trial started. And so from that, I think there were, if I remember correctly, 130 and then 60 that weren't. So 70 who were. And there was significant qualitative and quantitative discussions about what does it mean? Did you know? Did you like the process of disclosure that worked with you? And there's a lot of separate analysis on how that went and ways that could be improved, both in this context and across vulnerable settings.
Yeah, I think sometimes we don't realize, thinking of adolescents, depending on how young, we're including within there, but they're having their own experiences. And sometimes it's not always obvious, right? There's so much that's inside what impact that may have in terms of also their own future behavior, health-seeking behavior and so forth.
Definitely. And also having a doctor ask you the power dynamics of that and who's conducting the research can also change.
Exactly. Thank you very much, Liza.
Thank you.
And great job, amazing job, everybody. We're getting a lot of these thank you, great, amazing jobs. And now our final presenter, we're still staying, I think we're back in the US, but we're staying with HIV. A different study, we've got Amara Plaza-Jennings, MD PhD student. Amara.
Hi, thanks. So hi, everyone. My name is Amara. And as Dr. Rojas mentioned, I'm an MD PhD student and will be coming back to med school this summer, joining the current MS2s. And today I'm excited to share with you my PhD research project titled Altered Microglial Genome Structure and Transcription in HIV Encephalitis Impact HIV Integration. So HIV is a lentivirus that infects T cells and macrophages. There are over 37 million people living with HIV worldwide, with 1.5 million new cases in 2020 alone. And while antiretroviral therapy can inhibit the replication of HIV effectively, there's still no cure for HIV. And that relates to the way the virus life cycle works. So once HIV infects a cell, it enters the cell, undergoes reverse transcription, and the viral genome is brought into the nucleus, where it then integrates into the host genome. And this is the key step sort of preventing the cure of HIV, because once it's integrated into the DNA, it can undergo a reversible transition into a state of latency, where the virus is quiescent and not actively being expressed. And those cells with latent virus can't be identified by your body's immune system to then be targeted for killing. But if someone with HIV is to stop taking antiretroviral therapy, this latent virus can reactivate and seed ongoing infection. And this is a process that's happening not only in immune cells in the blood, but also in different sites throughout the body, including the brain. So HIV enters the brain early in the course of infection in the form of infected monocytes, which cross the blood-brain barrier and seed infection in brain resident cells, predominantly microglia, which are the immune cells of the brain. And so infection of microglia can lead to HIV encephalitis, which is characterized by inflammation of the brain and high levels of ongoing active viral replication in microglia specifically. And prior to the advent of antiretroviral therapy, 25% of patients would develop HIV encephalitis. On antiretroviral therapy, patients do not develop HIV encephalitis for the most part, but instead we see something called HIV-associated neurocognitive disorders, which is really a spectrum of neurocognitive disorders ranging in severity. And this is something that 20 to 50% of patients experience even while on antiretroviral therapy. But due to the challenges of studying the human brain, still relatively little is known about the mechanisms of HIV infection and pathogenesis in the brain. Most work that's been done looking at this has been done in T cells. And so what's been shown in T cells is that when a T cell becomes infected with HIV, it releases interferons and cytokines, which help to modulate the immune response in other cells. And so the release of these factors then causes other T cells that are not infected to be activated to enhance their sort of immune functions. And T cell activation causes changes to cell function at a variety of different levels. And one level of regulation that's important for this is actually the 3D structure of chromatin in the nucleus. So the DNA in the nucleus is highly structured, and there are different levels of organization to it, but one level is division of the chromatin into separate compartments. So broadly, these can be defined as an A compartment, which is a compartment with more open chromatin that has active gene expression. And then a B compartment, which has is a more closed chromatin compartment and has inactive gene expression. And when T cells become activated, regions of the genome can actually switch from one compartment to another. And in particular, regions containing genes related to the immune response will switch from this inactive state to an active state. And this is associated with increased expression of genes within those loci of the genome. And what's also been found in T cells is that HIV sort of takes advantage of these changes, actually. So T cells, for efficient infection of T cells, HIV requires the T cells to actually be activated. And when HIV enters the nucleus and integrates into the DNA, it tends to integrate more into these regions with active gene expression that have changed during T cell activation. And this is sort of advantageous to the virus because if the virus integrates in a place in the genome where there is active gene expression, the virus itself is more likely to be expressed, meaning it can produce new virions to go on and infect other cells, completing this sort of vicious cycle of infection. But this has not been studied at all in the brain, and it's unclear if the same mechanisms are true there. So to try to answer that question, we utilized postmortem frontal cortex tissue from HIV-negative control donors, as well as donors with HIV encephalitis, so that we could specifically understand what happens to microglia in the brain during active viral infection. And from frozen postmortem tissue, it's possible to isolate intact nuclei. So we do this. And then we can either utilize fluorescence activated nuclei sorting to separate specific cell types and then look at where HIV has integrated in the genome in those cells, as well as look at 3D genome structure using a method called Hi-C. Or alternately, we can look at gene expression in those cells using single nucleus RNA sequencing. And with these 3 data sets, we can really understand HIV integration in the context of local transcription as well as 3D genome structure. And so first here, we're looking at some transcriptional data. And in particular, we focused on the microglia because these are the cells that are predominantly infected by HIV in the brain. And so we're able to compare expression in microglia from brain with HIV encephalitis and compare that to HIV negative control tissue. And we see significant dysregulation of many genes. Those genes that are upregulated relate to the immune response, as we sort of would expect to see, and in particular, the interferon signaling, which mediates the antiviral response. And those genes that are downregulated related more to homeostatic microglial functions, such as cell adhesion or ion transport. So having seen changes to gene expression, we wanted to understand, are there also changes to this 3D genome structure that are relating to these changes in gene expression? So again, we looked at these different A compartments and B compartments, and these actually exist along a spectrum measured by this principal component 1 value, with high values being the most open and active regions of the genome, and the most negative values being the most closed and least active regions of the genome. And we can see if between HIV encephalitis and HIV negative cells, there's switching within these compartments. And we did observe that there was compartment switching of altogether over 6% of the genome, which is a large portion of the genome. And a slightly higher proportion of that was regions that switched to a more open state than switching to a more closed state. When we looked at genes that fell into those regions that switched into a more open state, we saw again that these related to the immune response. So we see regulation of virus, defense response, inflammatory antigen response, et cetera. And when we looked at the expression of those genes, indeed, we did see that they were significantly more highly expressed in encephalitic microglia as compared to HIV negative. When we look at those genes that switched to a more closed state, again, these related to these more homeostatic functions of cell adhesion, as well as neuronal support functions. So under normal circumstances, microglia physically interact with neurons and help to regulate their function. So we're seeing they're sort of switching away from this more to an immune function. And again, we saw that those genes that switched to a more closed state were more significantly, were expressed at significantly lower levels in HIV encephalitis. And so finally, we wanted to see how these changes to gene expression and 3D genome structure related to infection, in particular, where HIV was integrating in the genome, as well as the transcriptional status of the virus itself. So here we're looking at integration sites, specifically on chromosome 19. And what we can appreciate is that the integration sites are really only found in regions with active gene expression, as well as regions that are found in the A compartment or that open compartment. And HIV really avoids integrating into the central portion of chromosome 19 that has very low levels of gene expression and is found in the B compartment. And even more specifically, we saw that some of the regions where HIV was integrating were undergoing switches to compartment structure during HIV encephalitis. So a significantly higher proportion of integration sites are found in the A compartment in HIV encephalitis as compared to HIV negative, suggesting that it's preferentially integrating into those regions that are changing as well. And then finally, we looked at the transcriptional status of the virus itself. So in what cells was HIV actually being expressed? So here in blue, we're showing, this is looking just at microglial cells. And in blue, we see those microglia that are actively expressing HIV versus those that are not. And what you can appreciate is that the ones that are expressing HIV tend to cluster closely together, suggesting that they are transcriptionally different from the cells that are not expressing HIV. And so we wanted to understand how they're different from those other cells. And so if we look at the differences between these blue cells and these gray cells and compare that to the differences between all encephalitic microglia compared to HIV negative microglia, we see a strong positive linear correlation. And what this means is that we're only seeing active HIV transcription in those microglia that are actually activated in HIV encephalitis as well. And that's what's driving this differential expression in HIV encephalitic microglia. So overall, we see that in HIV encephalitis, there's 3D remodeling of over 6% of the genome in microglia, and this remodeling is associated with changes in gene expression Specifically, we see increased expression of immune genes and decreased expression of genes related to homeostatic and neuronal support functions. We saw that HIV preferentially integrates into regions with active gene expression that switch to a more open compartment state in HIV encephalitis. And we only observed active viral transcription in activated microglia as well. So these findings overall support a vicious cycle model of infection in the brain as well. And that vicious cycle may in fact contribute to the development of HIV encephalitis. And so going forward, we want to better understand the mechanisms of how the 3D genome restructures itself during microglial activation, and also how these findings relate to HIV-infected brains without encephalitis. And overall, this will help us to better understand how active HIV infection impacts the brain so that we can develop therapeutics to treat HIV-associated neurologic diseases. With that, I'd like to thank my lab, as well as all of our collaborators, the MSTP program, and especially the Manhattan HIV Brain Bank, where all of our tissue came from, and all of the tissue donors. And with that, I'm happy to take any questions.
Thank you. This is absolutely fascinating. I do have a few questions that were actually emailed in and so may not appear in the chat. Your two HIV cohorts are different. The HIV-E patients who are profoundly immunocompromised, and the HIV patients who have generally intact immune systems. What are your observations? What do your observations tell us about how these two different cohorts demonstrate neuroinflammation?
Yeah, so I didn't show any of this data here for the sake of time, but we did also look at some patients who who were HIV positive, but did not have encephalitis. We still saw some evidence for inflammatory markers in the microglia in the brains of those patients without encephalitis. And so that suggests that even patients who are on antiretroviral therapy who don't have very active ongoing viral replication in the brain, there is still some inflammation there. And that is certainly a potential mechanism that could be causing this HIV-associated neurocognitive disorder. And that's a very active area of research right now. Yeah.
Thank you. There's one more, and I'm not sure if your last bullet point tapped at this, but I will read it since it was sent in. You've shared a lot of very detailed information about the inflammation happening in the brain, and we are missing when we sample blood for our patients. And we are missing when we sample blood. What do you think we're missing when we look at peripheral markers of inflammation?
Yeah, so there have been some associations found between peripheral markers of inflammation and brain markers. So the blood could potentially show markers of inflammation going on in the brain, but not very reliably. And so another thing that many studies have done is look at CSF. And in some cases, we actually see inflammation specific to the CSF that's not in blood, and even active viral replication in the CSF when there's none in the blood. So there can be these sort of compartmentalized CNS specific viral processes that go on. And that is something that we miss by looking at the blood. So whether it's a matter of we have to look at CSF to see that, or if we can find different biomarkers in the blood that do better reflect brain inflammation, that's sort of what we would have to do.
Thank you very much. So I'd like to, not that I'd like to, but I'm closing today, and I don't have any wise parting words except just like OMG. I just think all these presentations have been pretty phenomenal. The breadth of your work is just pretty amazing. And to imagine that this work has been going on during all the changes with COVID, I think is a real testament to who you are. So thank you very much. And this concludes our Research Day event for today. And I look forward to hearing more about these research, and looking at your publications for this findings. Thank you, everyone. Have a good evening.